So, love and marriage was not actually even close to Regina. It was in probably Atlanta with Dr. Stein and his wife, and when Dr. Stein was full of dopamine and oxytocin, his wife said, one day when we have kids, we're going to live in a different country for a while. And he said, yes, of course. And then he proceeded to do all the work that he did in Emory to develop and come up with the ideas of an accountable care unit and have some kids. And then his wife said, it's time. And so Dr. Stein carefully planned communications with the country they were going to in order to set up a sabbatical so that he could continue to try to do his work around accountable care unit. And the country that his wife decided on was this one.
So in 2012 and 13, I was, as Director of Patient Flow, as many of you know, I was charged with kind of setting up a patient flow program for Regina Capel Health Region. And I was very fortunate to have the opportunity to go to Australia, specifically New South Wales, and learn from much of what they were doing. And on my last visit there, I was very fortunate to connect with the individual responsible for managing what they have branded In Safe Hands, which in essence was the work that they did in partnership with Dr. Stein in creating accountable care units across all of their hospitals. And their plan is to have it rolled out in all 705 hospitals within their state. So a very significant undertaking. I was able to witness and talk to frontline staff in multiple hospitals and multiple units. And one thing that struck me was that the focus around that entire inpatient unit was on the patient and engaging the entire care team in a very collaborative, standard way on managing the care plan and making sure they communicated with the patients and families and everybody else. And there was this amazing shared accountability amongst everyone. And certainly to the patient stories that Buck talked about, everyone is focused on doing what's right for the patient. And you remove silos, and everyone kind of knows that this is a collective sandbox instead of a whole bunch of individual sandboxes. So that was the first thing. The second thing that struck me was how calm the units were. I went to different units and they were all calm, and staff was smiling. And that was in direct paradox to what traditionally we would experience on inpatient units in our system, because everyone's running and managers are constantly told to do extra, do this, here's another one, new priority, and so on and so forth. And what realized to me was that at the time we were doing all this improvement work around trying to fix around the margins. And the accountable care unit was about creating a brand new model of care that fixed a lot of the root cause issues, specifically providing the best patient care that we could. I came back from Australia full of energy, and I distributed this concept and all the documentation and kind of said to a number of leaders within our organization, here is a model of care that I think will address many of the root causes that we're trying to fix with all these improvement work that we're doing. Didn't get a lot of uptake on it. I certainly own some of that, and I realized that you can't just send an idea out into email space and expect someone to pick it up and run with it. So I realized that from moving this forward, I needed to find a leader, a kind of frontline leader, leaders from a physician and nursing standpoint that thought this was a great idea. So I kind of readjusted then and said, okay, I need to find those people that we can engage at a frontline to kind of bring that proof of concept forward.
So the connection for me started a bit later. In the spring of 2014, I found this article, and the only reason I picked it up, because I'm not really much of an academic physician, it said hospitalist ward on it. And at that time, there was a nursing manager and some frontline staff who said to the hospitalist, you guys should have your own ward. And I didn't really know what that was or how to do that. But what I did know is that I sat on wards beside colleagues and other healthcare providers, and in this supposed world where we're supposed to be fulfilled in providing patient care, we generally survived it. And nurses that I'd work with, the main reasons they would articulate they'd do their jobs is so they could work 12 12s in a month, not go to Costco on the weekend, and all they had to do was drink wine after their 12-hour shifts, and they'd be fine. And that's kind of the work world we lived in. We survived it. So I had this article, and I carried it around in my briefcase kind of thing for the next 6 to 7 months. And one day I wandered through the patient flow office, and it's not like I was big buddies with John Ash, so I don't even know why I really went in his office and sat down, and we did this and just started to kibitz, and probably I complained a lot. And eventually it led to, and I don't even know who was first bringing it up, but I like to tell the story that I pulled that article out of my briefcase and I said, this is kind of a thing. And John said, oh, you mean this stuff? And he reached into his briefcase and he pulled out the same stuff. So that was sort of the serendipitous genesis of us being able to talk to the nurse manager on 4A at the time, Erica Peterson. And she quickly said, yeah, seems like an idea we could try. And we were on the phone with Dr. Stein the next week, and that sort of tipped the momentum toward the idea of a pilot. And in early 2015, John worked on the paperwork part of things and started putting together a proposal and to tap into some money that was there in the RQHR for the ED wait times piece. And on 4A, we tend to have about 10 to 15 hospitalist patients on that ward, so it kind of made sense for us. And the staff agreed to start practicing this thing called cyber, or structured interdisciplinary bedside rounds. And the big important part in this eventually is that frontline staff became the people that changed the culture. And there they are. So that the background on that slide is actually the same thing they have on their t-shirts there. And this nurse here, Jolene, she has the artistic bent, and she put a bunch of logos together for the staff to vote on, and eventually that's the one they came up with. And for me, it talks about a culture change. And I used to work in Emerge, and in Emerge, they always had their own swag. ICUs, they got their own swag, but never on a medicine ward. And so this was the beginning. And I put this picture here as well because there's a person here in this picture on the left who's a unit clerk, and she was kind of upset that she wasn't included in the selfie pictures when she wanted a picture of her and her stuff with everybody. So they redid it, and that spoke to me about the culture change that happened. And the other thing I want to point out is this is Sherry Bray, the co-lead and manager on 4A, because Erica Peterson stepped away after a while, and that was a big part of the development of our team. So that's another reason to have that picture. And then the other people that became really apparent early on in 2015 that changed this from, I want a better place to work where people aren't just surviving it to go drink and shop on Mondays, was patients. So this is Graham Parsons. He was a patient rep on the pilot committee, and that's his wife Penny that he's holding a picture up. And I won't tell his story, but just say he was really important in how we modeled 4A and built it. And I will tell one patient story though, because I think to me it represents us starting to know we were doing something the right way. So on 4A, only 10 to 15 patients a day were getting this bedside round thing, and there's shared rooms. And so the cyber team, who were just making this stuff up and figuring it out, would walk past the patient in the bed by the door because they weren't under the hospitalist, and they'd walk and do bedside rounds on the patient next to the window. And this happened day 2, day 3, and by day 4, the daughter sitting beside her mother in the bed by the door grabbed the Dr. Wildenbauer by the sleeve and said, how come we're not getting that? And how can we get you to be her doctor? So that became a big part of the motivation to get this done. And it took a little while to set it up. So the pilot actually ran in March of 2016 to August 2016. And this is the stuff that we wanted to try to find out. So the first was, could we even do it? Could we get the 4 features of an accountable care unit in place? And we more or less did, so yeah, we can do that. And then could we replicate some of the results of Dr. Stein and Brian Castle, who was his nurse co-lead when he did the work at Emory. And together they had 4 big groupings of findings. So what everyone in the patient flow world cares about is length of stay reduction, and we were able to demonstrate about the same thing, about almost 18% reduction in length of stay, and Dr. Stein was 10 to 15% in his study. And almost every accountable care unit that Dr. Stein's been involved with shows somewhere to 10 to 20% reduction in length of stay. Also, we paid attention to readmission rates to show that we weren't sending people out so they would come back. And they trended down but didn't reach statistical significance, so we knew for sure they weren't coming back faster. And then I want to mention the medical surveillance unit, because we kind of, Dr. Lister and their group, kind of on the sly built it as an accountable care unit when they started it. And their throughput through that unit compared to the year before they did it was twice as many patients in a year, which I'm going to bring up again when I talk about staff satisfaction. So staff satisfaction improved on accountable care units in Emory, and we found those 2 broad themes in the surveys that improved. And then the other thing that maybe people with budgets care about is human resource costs. So on 4A, staff turnover and churn dropped a lot, and if you want someone to talk to you about that articulately, you can talk to Sherry. And we know that overtime costs dropped by almost $10,000 a month on the nursing side. The medical surveillance unit, their training costs are higher because of the expertise of the nurses, and in 1 year, their reduction in human resources and overtime and training costs was about $400,000. And that's in a unit that put through twice as many patients as the year before. Patient satisfaction. So we didn't have the best quality survey stuff set up, so there's some holes in it, but generally speaking, the survey showed that there's a broad range of improvements in the patient satisfaction. To me, the biggest thing is stories and then advocate complaints. So the medical surveillance unit had 1 as opposed to the usual annual of 7, and that happened in their 52nd week of doing it. And it was a complaint about having to pay the ambulance bill, so it wasn't really about the care. And on 4A, over a full year of an accountable care unit, average used to be 32 complaints a year, and there was 3. And so Dr. Stein showed a 50% reduction in mortality in the accountable care unit at Emory. We showed a non-significant 27% reduction. So we don't know if actually that is real or not, but that's what we found during the pilot. We do know that code blues dropped from about 1 per month to half a code blue per month. And I want to bring up something else called unit-based metrics, which is a big part of an accountable care unit. And I'll lob this at any of the data people in the room that I watch put up slides about important data that is meant for an audience that is not necessarily the frontline care providers. And I think you have to remember where the edge of the knife is, and that's on the front line. And those people need feedback about their performance in order that they know that they're doing a good job and can feel masterful and enjoy their job, not just because they get to drink wine and go to Costco. And so we did some stuff to try to show that we could make change. And so Pneumovax, we were able to generate a baseline number of 1.54% of eligible patients were getting their Pneumovax before we established an accountable care unit. And nearly overnight, we were able to get that to 60%. And that's because we could measure and feed it back to the frontline care providers. We know the risk state of on a ward is if somebody is not getting prevention for the formation of blood clots, that's the risk state. And if we're doing that to somebody, we should know why. And so we were able to provide feedback and demonstrate that we could document why we were not giving VTE prophylaxis. And then we were really fortunate to have Roseanne Nasser, a research dietitian, involved in a study across the country called More to Eat on nutrition in the inpatient setting. And she has multiple graphs, but I'm just going to use this one. So this is the monitoring nutritional intake on a medicine ward, which in the past I would have told you is crazy to even try. The orange line is Regina. And if you can see, every of the 5 sites in Canada, they struggled to try to do this. And the pilot started right in April, May. And I'm not going to go into a lot of details, but I can assure you that this is an improvement. And if this, if I had the most recent graph that Roseanne has, that this is sustained and continues to this day. This is not an artifact of the study. And I used to hate this slide because it didn't look as good as the old slide, which used to cut off here, because these sites really seem to improve. But Roseanne told me it was because those sites phoned Regina and said, "What are you doing?" And they implemented some of them. So I'm going to get out of the way.
Certainly through the pilot and we engaged certainly the leadership of the organization, and I want to recognize Dr. McCutcheon and the rest of the medicine service line and some of the leadership in making, kind of supporting the pilot. But one thing that was clear to me is understanding this just wasn't about a Regina thing. This is really about how can we improve care for patients across our system. And so I spent a lot of time talking to Graham and his team and folks at the ministry to say, look, this is what we're doing. And obviously, as Ron alluded to, they were supportive in letting us redirect some ED weights funding to support the pilot. So I obviously saw this as an opportunity not only for Regina or larger centers such as Saskatoon, but more broadly. How do we take those principles and ideas and play them forward so that the patients who receive care in our province can do it in such a way that is collaborative and team-based, and really certainly as we move forward really aligns to the connected care strategy. So there's just this synergy coming together of things, which is I think really fantastic. And you know, there's so we're building on this idea and we're getting some successes, and you'll hear from Saskatoon and certainly Brian shortly, but I really want to commend certainly the medicine service line and David and certainly the province for really coming in behind this and supporting the pilot, but obviously looking at what we're doing and helping replicate that. So thank you for that. So
I'm just going to finish with the ripples stuff because I find it kind of interesting if you think that love and marriage started and the ripples landed in Saskatchewan, weird. But we also have had the good fortune to be able to network with some people in Ontario and in Cambridge and St. Mary's. They're looking at this model, and in Cambridge, I think this fall, winter, they're gonna pilot an accountable care unit there based on some of the stuff out of Saskatchewan. The Prairie North Health Region, a whole bunch of people from North Battleford and Meadow Lake and Lloydminster came down to Regina last month and spent a day, and hopefully they'll get something happening there and they'll solve maybe some of the problems that are unique to those smaller centers to see if they can implement this and look at some of the successes. Sherry and I really believe in the empowerment that this does for the frontline staff and freeing up their purpose. And these are two people that were really engaged with the work, and Nancy McGill is a pharmacist who's going to be presenting about working on an accountable care unit in Saskatoon this month at the Saskatchewan chapter of the Canadian Society of Hospital Pharmacists. And Alana is a young physiotherapist who jumped all over this and was somebody who you didn't have to pull to the water. She actually ran to the water. And because of her engagement with this, Dr. Stein was actually asked to present at Virginia Commonwealth University, and they specifically asked about physiotherapists, and he reached back up here, and she's going to go down and present with him in November. And we were just in Halifax. A whole bunch of hospitalists and their spouses from Regina went there to the Canadian Society of Hospital Medicine Conference. And you have to know that the people who are involved in the Canadian Society of Hospital Medicine think the country is Ontario, Alberta, and BC with this a lot of black stuff around those plots. So they were kind of shocked. Kish, his abstract and presentation around his work in the MSU, he won an award for his work. And I'm going to say that actually we're accepting these awards on 4A staff benefit. So Sherry and I won another award, I won an award, but they're basically reflections of all the work done on 4A staff. So 3 out of the 4 awards presented were won by this black spot on the map, which was kind of cool. But the fun part was I got to talk to doctors and people administrators from Victoria, Dartmouth, and Guelph, who all are kind of keen about trying to see if they can get this to happen in their hospitals and on their wards. And then the biggest thing that happened, I think, for us in Saskatchewan was this spring. These 3 people wandered down the road to Regina and spent a day and an evening listening to us BS to them about what we were doing and watching what we were doing. And they quickly came back here and have started some big success here, actually, which I'll just leave alone and Brian can talk about that. That's it.